So, hi guys, welcome to EthOss webinar. We're going over socket grafting and vertical bone gain associated with that today. Thank you for all making it over onto the webinar. It's a hot day. It's been 30 degrees in London and it's the hottest I've ever noticed or known it. So it'll be nice to get back and relax later. But running through this, we are going to just talk through a few things. First of all, just to give you a little sort of recap and understanding of where I've come from, what I've done. At the moment, I'm working with Peter Fairburn, who you'll have known through EthOss, in his practice in London, and I'm working in one other, which is Fresh Dental, where I'm placing their implants and working on a teaching program there as well. But over the course of my sort of work so far, I've restored over 400 full arch implant restorations. That was over 5 years in a full arch clinic, and placed over 1,000 implants since I started. And with the work that I was doing in a full arch clinic where it was only full arch day in, day out, I've monitored over 40,000 implants. So I've looked and had my eyes on a few. So this is just a little summary of sort of what I did for my first few years. It was a sort of resective approach where we take things out and we replace it with prosthesis and implants. And for the right patients, it's the right treatment. Although it's sort of not doing as much of this work now. More of my work now revolves around sort of single teeth and dental bridges and restoring dentate patients rather than edentulous patients. So this photo is sort of an example of sort of things I'm doing. Let me just close the door because it's a bit loud. So this is probably about 60%, 70% of my workflow, but I do still enjoy a little bit of restorative dentistry as well. I don't want to lose those skills and you just want to maintain them. So my sort of pathway into this was only working with full arch restorations, removing things, replacing them. And after a few years of doing this, I kind of came around to the idea that actually regenerating things, preserving things is a nice approach when you can. So now I'm in this sort of world of minimally invasive restorative dentistry combined with my sort of implant work. I'm finding that EthOss and the regenerative potential of the material is working well with the work that I'm doing. So this brings me on to using EthOss and what we're going to be talking about today. So the aims and objectives of what I want to get through and I want you to walk away with are identify sites that would benefit from some socket preservation. These are generally patients that are coming in with sites that you'd want to put an implant in the future, but are already reasonably infected. Majority of the cases that we're treating at the moment, we're treating them as either an immediate or a early sort of 5-week placement. So generally, I'm only socket preserving with those two if the sites are sort of heavily infected and there isn't a lot of bone available. I'll show you a couple of cases later that sort of help distinguish between the two. Now, I want you to understand what sort of protocol we're using and how we use that to get the same sort of predictable results that we're getting. And it's sort of become a mainstay of our daily practice. So why as well is it that we're using EthOss? So for me, compared to other materials that I've used, it's super simple, super easy to use. If I have the time and I have the right setup, I do enjoy putting a membrane in, but it's just time consuming and it can be incredibly fiddly. EthOss, I really like the simplicity of just being able to place it. Another huge advantage that I think is underplayed is the speed in which we can go back in. But if you have a busy implant practice and you're placing a lot of implants, it doesn't really matter if you go away and say you need to go away and wait for 6 months. But the only person that's really losing out there is the patient, because we've still got the same throughput of patients coming in. But for me, the advantage of saying it's only 10 weeks is it's just not as long. So there's no risk of cross-contaminants. There's also no comorbidity in taking donor sites. There's no issues with bone harvesting. It's really easy when we're using it. It doesn't take long at all. I sometimes forget to take the photographs that I should be taking when I'm documenting these cases so that I can present them, just because that part of the procedure is so quick. And we've had lots of studies to show histologically that this material is resorbed and showing 50% new bone in 10 to 12 weeks. So when we look at what we are trying to replace, we need to understand a little bit about the material that we've lost. So bone is a mineralized connective tissue, and with that it deserves a little bit of respect. Like any connective tissue, say muscle for example, if we don't use it, we lose it. Within bone there is a law called Wolff's law, and it talks about the stress and strain and how that influences the bone that we either do or don't have. So when I'm explaining this to patients that have sort of lost teeth or haven't had any teeth in a position for a while, usually use a sort of analogy of saying, if you didn't get out of bed or you lay in bed in a hospital bed for 6 months and then you got out, your muscles would have sort of wasted away. And in that area where you're missing teeth, the bone has sort of done the same thing. So in order to try and replace that, we need to place a small graft, but then we need to activate that graft and activate an implant in the site for you to preserve and hold onto the bone. Another thing as well that I like to get across is surgery is a controlled trauma. So whenever we do surgery, there has to be a risk benefit, and the benefit has to outweigh the risk, because every time we do something, we are affecting the body and affecting healing a little bit. So we want to try and control things and mediate them towards healing towards our favor. So let's have a little look through a couple of cases. So first ones that we're going to go through. Pardon?
Just before you carry on, someone's just put in the chat that they can't see his screen. I can see my screen. Yeah, I can see it.
Okay. Maybe if somebody else could answer, if we can ask the question out. Everybody there, can everybody see the screen, or is that just a technical issue on one account?
People are raising hands. I'm not sure what that means.
Okay, we need the PowerPoint bigger as it's just too small. Okay. Yes, I can. Yes, all good for me. See if we can just change that a little bit. There's quite a few yeses there, so
yeah, I think we're good to carry on. Okay. Obviously, if anyone else can't see, just let us know. And
that's right. Pierre, have you managed to sort it out? Can you see the screen now? We've also got an Alex saying the PowerPoint is too small. I'm not sure how we can make it any bigger, because that's just showing a complete screen. It's just black. Can see the speaker. I'll log out and back in again. No worries. Okay, so Pierre's going to log in and log out.
Cool.
Okay. So when it comes to socket preservation, what we're really trying to do is maintain that sort of alveolar bone that we have around the crest of the implant, or crest of the alveolus. So if we lose that, it becomes far more difficult to replace it and regenerate it than it is to preserve it and keep it as it is when the tooth is there. So the real philosophy for preserving that is to try and reduce the need for future surgical interventions. If we can hold on to it, we can avoid large grafts that might be more expensive, more uncomfortable for patients, and have a higher risk of failing. Sort of comes down to that old sort of try and keep it simple. Another reason is when we're already taking teeth out, that's the first surgical intervention. So if at that surgical intervention we can leave things better, or we can upregulate healing, we can try and encourage that site to be better 10 weeks later than it otherwise would have been, which will mean we've then got an easier site to manage. And of course, upregulating the host healing to work with you. One of the things that my mentor and friend Peter Fairbairn always said is try and use host healing to work with you so that you can spend more time at the beach. Now, he's probably not spending enough time at the beach at the moment because we're both working hard, but it's something that is to come. So this is an example of a tooth that I tried to restore with an onlay, but when we got to it, there was a vertical root fracture and there was some movement and mobility. But we decided to extract it. And if you have a look here at the sort of distal bone loss around the back of the tooth, you'll notice that as we go through this grafting procedure, we'll be improving that, and then we'll be improving it once we place the implant as well. So here we can estimate that we've got about 5.5 to 6 millimeters of bone from the crestal level to the floor of the sinus, and from the cemento enamel junction to the bone level, we've got about 3.5 millimeters of space. So you'll see that space reduce with the grafting. So one of the things that we know about taking teeth out is lots of figures sort of being thrown around, but the most important one is that we can lose up to 60% horizontal bone and 20% vertical bone at 6 months. So 60% horizontal bone loss at 6 months is quite a lot to try and build back. So we're trying to hold on to that, and that 20%, up to 20%. So we do see this in cases that come to us. And this one has lost a huge amount. It's also lost a huge amount of keratinized gingiva. So this case, for example, had it been correctly socket preserved, would be far easier to manage now than it is currently. It's going to take a little bit more work to manage that to get it to work. But we don't just see this, well, we do see this bone loss in teeth like this, but we also see evidence of it when we fit immediate dentures. So we can see that we've lost a majority of sort of horizontal and some vertical loss there just over the sort of first few weeks of that denture being in place. Now we can do little tricks with the sort of soft tissue to sort of improve those contours. But this case has also been managed with some grafting, and that is the photo is the pre-op. The last photo there is the healing abutment is before we went to final fit. So you can see that the contour is improving, but that is with some grafting and a little bit of soft tissue work as well. This is what we're trying to really aim for. We're trying to get from these defects that we see on the top left there, where we have this sort of concavity, where we actually want to replace it with this sort of normal alveolus convexity. One of the things when we place implants, it's easy to place implants into sort of residual host bone, but what we're really trying to do is we're trying to place implants into sites that sort of disguises them a little better and gives you the perception that they might not be implants, or they look more like teeth. The other huge benefit from a patient's point of view is with the soft tissue thickening out these embrasures, you're far less likely to get sort of food impaction than you would if you were just to place an implant in that top left site and say graft the sinus. Because we've increased the vertical bone height and the vertical support for the soft tissue through increasing the bone, we've increased and improved the outcome for that implant. So the indications for socket preserving: one, we're obviously trying to reduce the shrinkage of the bone that we get with extractions. We're trying to preserve the bone and the soft tissue to keep more of what was there. Particularly where I use it the most at the moment is large infected sites and older patients that perhaps don't have the same healing potential as a younger patient, and future implant sites. So these bits combined. So a couple of the cases that I'll show you later are hugely infected areas that my feeling is if we hadn't done what we've done, we'd never have an option to place an implant without huge grafts, delayed grafts where we're grafting and then placing at a later date. And just for pontic sites and the bridges, we can do it. So the objective really is to stop things collapsing and to save the patient time and money. We're also saving ourselves time and money because we're avoiding all those additional procedures. So this is an example of a 93-year-old patient that wanted this tooth, number one, not to hurt anymore. And Emily, if you just turn your audio off. So an example of a patient that's come in and wants a tooth. She wasn't sure if she wanted a tooth replacement or not. She said, I'm 93. I might decide that I just would rather give this money to my grandkids, but I actually think maybe I want this tooth to chew on as well. I said, okay, that's fair. We'll prepare everything for an implant and we'll see how we go. So we took the tooth out and we immediately grafted. And one of the important things about these cases is that I haven't overgrafted. The only time I see any grafts not performing as well is when we overgraft. So if we look at where the graft finishes, it's just below the crestal bone level and it's well below the soft tissue. A couple of cases that I've seen where people have tried to do this and it hasn't worked is when people have grafted right up to the top of the soft tissue and the graft doesn't perform as well. So you need to stay just under the crestal bone level. And really, the aim and the objective is to try and improve this volume of bone here so that we can place. And even if we have to additionally graft when we place, it's no problem when we're using EthOss, because we can leave this for 10 weeks, come in, place, and graft again. So there we've got our EthOss. And I'll just take you through the first sort of 12, 15 weeks of this as it consolidates. So on the left there, we've got the graft as it went in. And on the right, first week after, when she came for sutures removal, I wanted to take a little photo of this just to have a look at it. And you'll notice that it starts to darken. And this isn't a problem. It's because the bone is starting to turn over into osteoid. And you're getting all the early stages of bone change. And it's not mineralized yet. It takes at least sort of 6 weeks for it to start to mineralize. So you will notice initially, and the sort of first thought is you look at this and you think, God, my graft is sort of dissolving or disappearing. It's not. It's just the beginning phases and stages of healing. Then we get to this position where we are, I think this was sort of 8 weeks later and perhaps 12 weeks later, where we've got a sort of an alveolus that is probably perfect to place an implant. And the grafting procedure that's going to happen here when you place an implant is really just a sort of buccal veneer graft to sort of slightly improve the conditions for the implant. You could almost get away without grafting, but I would just graft at the same time as well, just to give a better result. But she did decide not to go ahead with the implant because she did decide that she would rather save the money for her grandkids. So we didn't get an implant there, but we did get a nice socket preservation case. And you can see we've now got up to 6.9 millimeters of bone. And there's just a little recap and summary of what happened through the course of that treatment. So the materials that we can use for our socket preservations range from allografts, which is obviously bone from another human, autogenous, which is from the patient, which I've done a couple of these, but you've obviously got the extended surgery time, and you've also got donor site, slight donor site issues. I know some guys that do this a lot get brilliant excellent results, and obviously different materials for different circumstances. Xenografts as well. I do see some very good results with some bone grafts and xenografts, but I've used these as well in the past, and my preference is now with synthetics, and it's just what I've been using for the last 5 years. So I've been working with Peter and Minas, and this was an article we published in 2019, and it really compared synthetics to sort of traditional xenografts as materials for upregulating healing and bone augmentation. So I'm slightly biased when it comes to which material we should or shouldn't use. But the science sort of sways and leans in favor of using synthetics as well. So if we look at these figures, and these are all compared, so this is the amount of bone that was found in grafted sites, socket preserved sites over a course of about 10 weeks. And it was looking at what percentage increase there was compared to control. So allograft and autogenous were pretty similar at 20% increases. Xenograft was anywhere from less than 20% to more than 9%. And alloplast synthetics were from about 6% up to 23% increase. So this was all compared to control, and we're looking at that 23% increase. And that's with the material that we're talking about today, EthOss. So really the only way to really tell what material you're using and how it's turning over is to take a core sample. So this was done at length and extensively with the University of Freiburg. And this was Dr. Minas Leventis and Peter Fairbairn taking core samples before putting implants in and having a look at the results. And the results there showing us that we've got 50% vital bone and only 8% residual EthOss. So it's a regenerative material that resorbs at just 10 to 12 weeks. It's leaving bone and the precursor to new bone in the site. It's not sticking around and staying in the body. By 12 weeks, it's nearly completely resorbed. So as a function of that, what we're getting is healthy physiological bone that performs and behaves more like native bone rather than a sort of space maintainer or a space fill. These are a couple of the core samples. The one on the right, we've actually got a huge poster of that on the wall because it almost looks like an album cover. Maybe that's me getting carried away. But this is an EthOss particle surrounded by new bone. And on the left, you can see the same as well, granules of EthOss surrounded by new bone and connective tissue. So the new bone and the connective tissue working together with the EthOss to produce new bone. And in a healing socket, it's an indication that the material is osseo-inductive rather than bone just being conductive from around the outside. We've got bone forming from within the center of the clot. So what are we doing in practice? So osseo-inductive EthOss as a healing stimulus to upregulate the healing. And then I'm also just using a collagen sponge just over the top, just to protect the EthOss and protect the blood flow. So first case to go through showing socket preservation, and this is improving the site prior to placing an implant. So this was a patient that came in again for an implant. And you can see this huge defect on the distal side of this retained root. Really difficult to manage that if we just take it out and leave it, or if it leaves and if it heals at that sort of bone level, or we don't get much of a sort of return of that crestal bone level. So if we look at that mesial wall of that upper right 7, we've really lost bone probably up until about halfway down the root, if not a little bit further. So as we go through this, we gently take the tooth out, or as gently as we possibly can. Degranulate and clean the site. Now, I'm thorough with the cleaning in terms of removing all the granulation tissue, especially on the walls within the bone. If there's any granulation tissue around the periphery at the top, and I can sort of keep it nudged out the side and lay it back over. Sometimes I'll just keep a little bit, but I won't keep any that's in contact with bone. But what I want to see in that degranulated site is nice, healthy bone bleeding. If I don't get lots of bone bleeding, I'm sometimes a little bit concerned and I might undergraft. Because what we want to see when we place the graft is that actually we're getting a sort of bleeding red contamination of the socket and of the EthOss. So this is giving us an indication that that's going to heal well. Now here it is on the left, that's just got a small collagen sponge which has just been squashed down, holding it down. And really that's really just there for my peace of mind. I know others that do these socket preservations and just leave the material, hold a dry gauze over it, let it set super hard, and then leave it uncovered. I've done it once and I was pretty impressed, but I just have a habit of putting these collagen sponges over the top just because I like to do it. And I like to put a little cross mattress over as well, just to keep it all down. But this is the radiograph of that site immediately after we placed the graft. And then this is a comparison of the site prior to extraction and 10 weeks later. So 10 weeks later, we've taken the tooth out, we've let it heal, we've upregulated the healing to a point at which we've got a nice residual alveolus to place an implant in. Now there's probably about 6 millimeters of bone there, which is enough for us to place an implant, either with a small sinus lift or with a little bit of a veneer graft over the top. So we did small sinus lift and a little bit of a veneer graft in that case. So managing not all the teeth we treat are taken out here. Lots of them are referrals. So sometimes we get cases coming in, teeth have been taken out, and one of our other protocols that we regularly use is the sort of early delayed approach, where we're going in at 5 to 6 weeks. The benefit of us going in at 5 to 6 weeks is that we are basically utilizing the benefit between soft tissue healing and hard tissue healing. So at 5 to 6 weeks, the bone hasn't really started to model yet, but we've got nice soft tissue overlaying over that extraction site. And we get all the benefits of having the periosteum cover the area after we've grafted. So this was how the case presented. Tooth had been taken out about, I think this was a bit longer, 7 or 8 weeks ago. Reasonable defect underneath. Does look like there's a slight issue, maybe a bit of granulation tissue, but I decided let's have a little look and let's have a look and see if we can place it at the same time. Once we were in there, I quickly realized that there was a lot of granulation tissue. You can see it all around the side there, and we probably only had about 2 millimeters of bone. And with the appearance of the bone just in the floor of the sinus, I wasn't bothered about trying to lift this. So I just decided that we were going to degranulate and place some EthOss and then come back just 10 weeks later. So whilst I degranulated, very careful, but I did cause, there's a little sort of, well, quite a reasonable tearing in the sinus floor there. So what I did here was I just lifted the floor of the sinus a little bit further. I squeezed a larger, a cut section of a collagen sponge down into the area that I'd created by lifting the membrane. I was comfortable and confident that that was a snug fit, and then I grafted over the top and closed. One of the things that I do when I'm closing is to try and make sure that I know I'm not over grafting, because when you have the syringe there and if there's a little bit extra left, the tendency is to try and put more material in because you just want more bone. We think more material, more bone, but actually working with the body, we're not going to get more bone than should be there with this material because we're up-regulating healing. So we don't want to add too much. So one of the ways I do that is I press the flap back over the top. I make sure that I can get sort of tension-free closure before I try and place any sutures. What I don't do is try and use my sutures to pull the flap and hold it down. I like to hold this down for probably about a minute or so, just to make sure it's sort of nice, rested and relaxed, holding in place. And then I put a couple of sutures in, just holding it down. But these are the radiographs as well. So you can see this one on the left, that was immediately after the EthOss went in. And it does look a little bit unusual there at the bottom. There's obviously the bit of granulation where we cleared out, but that's looking a lot better just 10 weeks later. Now that site at 10 weeks was perfect for us to place an implant with a small sinus lift. And you can see in the next photo, we had about 5 millimeters of bone. So we just continued through that case with our normal sinus lifting procedure. And there is a little review and recap just to show how the material has benefited that site. So the mesial aspect of that adjacent tooth. One of the things you might notice is that on the first approach, because I'd noticed that bone, I'd done a full thickness flap all the way up to the tooth, and I'd grafted the side of the tooth. When I came back again to do the sinus lift, because the site had been improved, I went for a papilla sparing incision so that the area under there was sort of maintained and a little bit more stable. And there we have that improvement in the bone on the mesial of that tooth. So in summary, when we're looking at socket preservations, we're applying the material straight. We can apply the material straight into the socket. That makes it really easy. We shouldn't be overfilling these sites and sockets. And really, we're just trying to improve the site so that when we come to visit it at an additional appointment, we just got somebody's audio. There we go. So when we come to visit the site at a second appointment, it's easier for us to manage than it would be if we left it alone. So having a little look at some cases with vertical ridge augmentation, sort of improving sites. Really, we're just trying to improve the bone height to allow an implant to be placed. And obviously this is because of anatomical factors that are preventing us from placing. So sometimes in the maxilla, this is obviously the floor of the sinus. We can get around that with a sinus lift. But even when we do sinus lifts, we also want to just improve that sort of bone level on the crestal bone position as well. Because if there's been some bone resorption, you're looking at very long crowns if you don't do that. And in the mandible, we're obviously avoiding the inferior alveolar dental nerve. Obviously, there are other procedures like nerve lateralization, but I wouldn't be bothered about doing any of that. So, crestal sinus lift and vertical bone gain. So this is an example of the case that I touched on in the very beginning when I was talking about that initial bone loss that we get when we take teeth out. So this case was managed with a sinus lift and some vertical bone gain. And one of the things that we can look at here is the position of the bone on the distal tooth. So if we look at this as well, after that tooth had come out, we were looking at about 4.5, 5 millimeters worth of bone, just enough for us to place an implant, sinus lift, and graft over the top as well. That line is really just there for us to show the difference. So that line's been drawn between the cemento enamel junction on the impressions appointment, just to show the bone improvement from that initial position. And there we have the final crown with a stable bone level in front and behind. We've gone from 4.9 millimeters. I think I measured this. I don't think I have an image of the measure, but on the computer downstairs, it's estimating that length to be about 11.5 millimeters. So we've gone from a 4.5, 5 millimeters to a 10 to 11 millimeter volume of bone and a stable implant. I have got a measure, so about 10.5. And you can see there, we've got about 1.7 measured from the cemental enamel junction to the top of the bone. So that's a dramatic increase in the amount of bone on the mesial side of that tooth. So this is another case. So this one just shows how a sort of isolated grafting procedure can improve the circumstances for placing an implant. So that first slide there on the top left is the sort of presenting condition. And you can see that steep slope coming down, and there isn't a huge amount of space above the alveolar dental nerve. On the right-hand side, you can see the site after it's been grafted. Then in the bottom left, you can see after 2 implants have been placed, albeit these are short implants, but we are still close to the inferior alveolar dental nerve, probably about 2 millimeters off. And then we've grafted again over those at the same time. And one of the benefits of using the material is that you can graft and then 10 weeks later, you can graft on the bone that you've sort of regenerated. So it's a very sort of user-friendly protocol when it comes to regrafting. And the outcome down there is, we always look at these and we'd like to see sort of more bone, but it's the outcome there has given us those 2 teeth in a position that would have been difficult to do otherwise. So another case that we've got, posterior mandibles. This is sort of pre-treatment with implants, a little bit of tunnel grafting. This is actually using a mix of EthOss with slightly larger particles. This is something that Peter's been working on and something that we're going to be, I'll talk about a little bit at the end because we've got something coming up based around new materials, new products and new techniques. But this is an example of, again, a posterior mandibular site where we've got a sort of less favorable position or less favorable bone layout. We've grafted over the top. And if we look at the site 10 weeks later, you can actually see how the jaw has sort of adapted to having had that grafter. It's almost sort of just flattened out a little bit, but we've got more material there. and a increased available amount of bone for us to place and regenerate. So whereas before we had a slightly steeper angle, we can see now we've got a flatter angle, and those arrows just help us determine how much extra additional bone we've developed. There it is again. So in summary, when we're socket preserving and sort of augmenting over the sites, we're really just trying to upregulate healing and improve outcomes. The material is a little bit of a get out of jail card because it just improves things enough for us to get away with things that we otherwise wouldn't be able to get away with. I've mentored a colleague who's very familiar with placing xenografts, and there was a case that we decided to abort simply because it didn't look favorable to placing and grafting at the same time. But it was a case that I would have been very comfortable grafting with EthOss. But again, that's just my opinion and perspective because I use the material a lot. So we're trying to reduce the number of surgeries, interventions, and time that the patients are undergoing these treatments. And with socket preservations, we're not necessarily trying to completely fill the sites. We're really just trying to improve the site so that when we come back to it, it's better for us to manage it the second time. And we can always graft for a second time once we're there. So that really sort of concludes my presentation and my talk on socket preservations and augmentation over the site. I mentioned that we've got a couple of, or we've got a sort of teams sort of discussions meeting that's sort of open to practitioners talking about materials that we're going to be using in the future and people having an opportunity to influence the direction way in which these go. If you're interested in that, just take that email down there to Pete Wheeler. He's our sort of manager at EthOss, and he can give you more info on that. So there is a huge community with EthOss as well. It's based on Facebook with over 10,000 members. If you've seen anything in here that you're interested in, I'm posting reasonably often, but there's people like Dominic there. His name's just at the bottom, but Dominic and Peter are posting all the time. And if you do want to connect or ask me about anything that you've seen or I've shown you, my Instagram is there as well, just so you can find me a message so that you can do. Emily, if there are any questions, we've still got.
There is lots of questions.
Okay.
We'll pick a few. So here's one. Do you use the degranulation burrs or other instruments? If so, what speed do you use for the burrs?
What speed do I use? I probably use it at about anywhere from 400 to 800 revolutions per minute. But I don't always flat press. So I mean, with my implant motor, I can sort of half press, flat press. It's almost like an accelerator. I don't always go all the way to the bottom. It's not sort of pedal to the metal. It's sort of as slow as it needs to be, but as fast as it has to be. I mean, it's all tactile and it's all feel. But I do use degranulation curettes as well. I quite like having those handy because I like trying to get these bits out in one piece.
Brilliant, thank you. And then we've got quite a long one here. It's a bit further up. So it says, so he socket preserved a site today that had poor gingival healing, filled after degranulation with EthOss, but could not get full gingival coverage. Thus material exposed, stabilized with cross suturing. Will this be okay to epithelialize normally? Yeah, so that one, that's a really important one in terms of how much material you put in. So earlier on one of the radiographs, I was sort of touching on the base of not overfilling it or leaving it just below the crestal bone level. I mean, unless you're trying to grow it up the side of a tooth, you really want it to be just underneath the soft tissue so that you're basically giving the material the opportunity to heal as one piece, rather than it trying to heal at the same level of the gum as well. So I think as long as it's not overfilled, where is that question, just so I can read it? It's quite near the top. It's from Mark It was at 7:15, if that helps.
Okay.
If you open the Q&A.
I don't seem to have one at 7:15. Mark, 7:16. Question: when appropriate, I socket preserved a nasty site today that had poor gingival healing, filled after degranulation with EthOss, but could not get full gingival coverage, thus material exposed but stabilized with exsuturing. Yeah, so that probably will be okay. Like I was saying earlier, I have a habit of just putting a flattened collagen sponge in over the top. I've done cases where I haven't had a collagen sponge. I've just let it set. One of the important things if you're going to leave it uncovered is you have to make sure that the material is set. I think when you're using this material in the beginning, and one of the mistakes I made was not holding my gauze down on it long enough for it to go solid. Especially if you've got it in a site that's perhaps got poor gingival healing and it's maybe bleeding a lot, you run the risk of losing some material. So as long as the EthOss is set and it's hard, that bleeding will actually help you a little bit. So it'll make sure the bleeding is obviously the mediator for health. If things didn't bleed, we wouldn't heal. So I think if you've got poor gingival healing, there's probably going to be a bit of bleeding. As long as you haven't overfilled it and it's set, it'll be fine. But I would sometimes in that situation just complement it with a little squashed collagen sponge just to keep it all neat and hold it down.
That's great, thank you. Just following on from that one, someone said, have you got any other tips if the socket isn't bleeding after cleaning? How densely packed does the EthOss need to be?
So if the socket isn't bleeding after healing, and this can happen if you've got a reasonable site that you're trying to degranulate. One of the things that I actually do is I disturb the gingiva around the site just to try and get a little bit of bleeding. Because I mean, if you've used something like articaine and it's really sort of over the sort of the time of the procedure, and if you've been degranulating really well, you can get to these positions where you've got a socket that isn't really wanting to bleed, especially if it's had a huge amount of degranulation in there that you've taken out. So sometimes with these bigger cases, if there's a little bit of degranulation tissue that's sort of on the periphery, I'll try and nudge it to the side, make sure the bone's all clean underneath, and leave a little bit of granulation tissue at the top, because that just sort of sits on top of the graft. And I mean, the granulation tissue has great blood supply as well. So if you haven't done that, or if you don't have any granulation tissue that you can do that with because it's all at the bottom, what I'll do is I'll just irritate the tissue around the top to make it bleed so that I've got a nice blood clot starting to form as I'm closing it. The last thing that I want to do is leave EthOss looking completely white and not looking like it's going to be contaminated with blood. It looks great in photos, but I think dry white EthOss isn't brilliant. I want to see some contamination with blood.
Well, thank you.
Gareth has asked, how do you stop the EthOss washing out in a socket like that? As I presume you won't get much mucosal coverage. So again, really what I'm trying to do is I'm trying to make sure the material is set hard, and I do like to put that little collagen, sort of collagen. Let's just go back to. So this case here is kind of the most basic, sort of normal socket preservation that we tend to do. So tend to take the tooth out, degranulate. Once I've degranulated, I do like it when I can see a lot of bleeding. Tends to be, if you just see white bone and there isn't a lot of bleeding, I actually try and irritate some of the tissue to make it bleed. And then I go in with the EthOss bone graft. And then once I'm in with the bone graft, I basically squash a squashed collagen sponge in over the top. One of the other things that does is I make sure the collagen sponge is underneath the soft tissue. And the benefit there is you're going to struggle to overfill that site and put a collagen sponge, even though it's squashed just in top. It's kind of just like a little bit of a check to make sure you haven't overfilled it as well. So another one there saying, do you get primary closure with periosteal release? The more surgery, I used to do huge periosteal releases, and I actually find now I'm doing sort of less and less. I really appreciate, it's a bit like the bone. Bone is a mineralized connective tissue. If I press and squeeze it and squash it too hard, I tend to reduce the blood supply to that bone. And I do think that even though it's mineralized, I do think you can squash the blood supply out of the bone. With periosteal release, it's kind of just my opinion, but I'll do a small one if I need to, but I'm trying to perform my surgery so that I don't have to. One of the problems with huge releases is obviously you lose the sort of vestibular architecture that maybe you correct with further surgery. But you're also pulling that mucogingival junction down closer to your sort of working site and working area. And actually, I almost don't want to interrupt the blood supply that's sort of coming to the periosteum. I know the periosteum is damaged as soon as you've raised it, but I just think putting a huge slash through it sort of inhibits that blood supply even more. So I try and avoid periosteal releases if I can. If I have to do it, I do it. But I do sometimes have a little bit of secondary intention healing. And when I say a little bit, I mean maybe 1 millimeter, max 2 millimeters. No more than that. There's another one there from William. In a socket preservation case, how do you promote a primary intention closure of the soft tissues? Yeah, so the simple answer there is you can't. So more and more now, what I'm finding is I'm placing immediately and placing a custom healing abutment, and that's giving me primary closure, and that's probably one of the ways that I'm getting my absolute best results. And it's actually almost one of the easiest techniques as long as the bone underneath allows you to do it. The results that you get are really nice, and you turn around to your tray and you just see it and you go, wow, I haven't picked up my blade, I haven't picked up my sutures. It feels really nice and clean, and generally those cases go very well. But in terms of the socket preservation case, like the ones that I've shown with a huge sort of defect, I tend to be covering just with a collagen sponge and a little cross mattress suture like that one shown there. Another one from Yuli Gertzberg. There you go. After socket preservation, if the patient can't go for implant in 12 or so weeks, what is the longest time implant can be postponed without losing the bone? 6 months, 12 months? You can probably leave it. I mean, this now comes down because it's sort of turning over into sort of physiological host bone. It's sort of it behaves similarly. Really, if you do leave it a little bit longer, you'd probably be thinking that you might be doing a sort of small onlay graft or something small just to benefit the placement when you do, just to improve the soft tissue. But generally, you want to be getting in there sooner rather than later. Another one from Sarit. What's your protocol of socket preservation? After placing the graft, do you place a collar plug prior to suturing? Exactly. So just as I've been showing, or just answering, I probably didn't answer this around 7:25 well enough, or explain it. But the protocol for socket preservation is the EthOss goes into a thoroughly clean site, and then I'm placing a little collagen sponge which is squashed. So I hold it between two fingers and I squash it down tight, almost creating like a sort of small membrane. But it's just something that just sits on top. And it just gives me peace of mind that there isn't anything there, or that it's less likely for anything to be disturbed. Could we go for the EthOss? Yeah, I've done this, and I kind of have had mixed results. I think and what I actually, so Seema Shuma saying, can we mix EthOss with autoallograft? And yeah, I think because I came from, I had a little bit of a background where we sort of treated the bone. We were incredibly careful with it, kept every sort of millimeter. After every slow drill, we were sort of holding onto bone. So yeah, so my interpretation was as well, why can't we mix the two? But I've had mixed results. And Peter Minas's opinion, or when I sort of asked Peter about it, he sort of said, well, I mean, all that bone is dead, and it's not, some of it's not going to work as well. I mean, the results that we get with EthOss alone seem to be too good for me to need to mix them together. So I just haven't had as good results as I thought I would have done. So I just use EthOss on its own. I think we answered that one on degranulation burrs.
Yeah.
And debridement. German Girona. Do you have long-term follow? If so, can you gauge stability of period? Yes, so we do have some PA and CBCT images with follow-up more than a year. We should be. I'll probably get Peter and I will probably put these cases together and post them on the EthOss group at some point. Could you explain how to dehydrate EthOss in a sinus lift case? So sinus lifts are really interesting from German Girona. So we've come up with a recent protocol that works incredibly well. Well, I say recent. I've been using it for the last year. Peter's been doing it for years. But it's much better than my previous protocol of just using Versa burrs alone. Basically, we use a DASC system, which has a little hydraulic, fires water through the middle of a round diamond burr, and it basically fires water up through the middle, and that hydraulic pressure helps push the sinus membrane up, and we get really good lifts underneath with EthOss. And I tend to go with a slightly wetter mix. I say wet. It's not wet, but it's just sort of, it's not dry. It's basically malleable. I put that in first, and then I go behind with a slightly drier mix. But I haven't had any issues with that material not dehydrating. When you do lift with the EthOss, I always find that I get a really nice dome shape. And when I place my implant into that dome, the EthOss just pushes back a little bit further as well. And we've sort of had this case series now getting really good lifts. So I haven't had an issue with the dehydration of the EthOss underlift. I think that might be a problem. Happy to go over that one further with you, Jaman. Try and understand what's going on there for you. Islam, when are you increasing bone height? What do you do exactly step by step? So really, it's very simple. I'm basically just making sure that the surface of the tooth is clean, and there isn't any granulation tissue in that area, and I'm letting the EthOss sit next to it. And I'm just closing and then leaving it for 10, 12 weeks. And the material is really then just doing most of the work for me or for us. Yeah, that degranulation bill was answered. Do I use ABC with socket preservation? Not sure exactly what that ABC is. Maybe if Stephen Davies, if you're still there, if you could just clarify what ABC is. Do you have any experience using mix of bovine and no, I've never mixed the two. Like I said before, I've mixed it with autogenous, but I've not mixed it with bovine. I have seen people having a go at that, and some people seem to get reasonable results. Jaskill, any other tips if the socket isn't bleeding after cleaning? I tend to pack the EthOss pretty tight, just so that I get a nice tight, solid material that's left in there that I know is going to be stable. I think if it's not densely packed, you run the risk of it being unstable. But if it's not bleeding, I basically just irritate the tissues around the top. I try and get blood flowing in from the sort of periphery and the gingiva around the top of the extraction cell. What is the
from Stephen? He was referring to the antibiotic cover.
Okay. Only if I'm very close to the sinus, maybe. But to be honest, not really. Just because on a local level, you sort of clean it as long as you've degranulated and cleaned really well. I think there's an ever so slight bacteriostatic nature to the EthOss, which can manage very, very small issues. Obviously, if there's infection there, I'd either be delaying managing it first, or so if there's a suppuration and pus, then maybe, but I'm probably trying to delay those and manage that first and clean it up before we work. But no, for the most part, I wouldn't. The only time I did use it was with the case that I showed you, where whilst I was degranulating, I caused a little perforation through to the sinus. So I used it there just to be a little bit safer. But for the most part, no. I don't find that we see a huge number of infections. What are the, okay, what else have we got? How far under, so how far under the graft, tend to like to place about, probably about 1 millimeter just under the crest. So around the crest or to the crest, you're all right. You just want to make sure that you're not over the crest. If you're over the crest, the graft seems to sort of almost get challenged by the oral environment, and there isn't really space for a healthy blood clot to form in between the graft and the soft tissue. So really what you're wanting to encourage is a nice blood clot just over the top, just so that it goes through normal sort of secondary intention healing, and it just protects everything that you put underneath. At the lower jaw, you could augment. The lower jaw, if you could augment vertically, do you use a membrane? So the reason we don't use a membrane is because of the sort of the healing potential of the periosteum. I mean, even Istvan Urban is talking about using membranes with holes in. So the membrane really, in those cases, as far as I can see it, is just there to sort of support and provide stability to the material that you put there so that it can turn over into bone. I do think there's probably, I haven't tried it yet, but I do think there is a case for us using maybe a titanium mesh to hold some of this material in the lower jaw. How long do you normally allow it to set? I used to do 5 minutes, but found that isn't long enough. So one from Gareth there. 5 minutes sounds like a long time. So I probably usually let it, I mean, as soon as the EthOss goes in, my nurse is waiting with a little sort of sterile, dry dry cover just to go over the top and compress. And I usually find anywhere from about 2 to 3 minutes, depending on how much peripheral bleeding there is enough. But I let it set and then I cover it gently with the soft tissue and the flap. Do you mix? So no, not done any mixing, just as we mentioned. Protocol for degranulation. So we do have some EthOss degranulation burrs, which do work very well for just cleaning the bone. But I use them alongside using curettes and things as well. In an extraction appointment, you don't always want to have to pull out the sort of implant motor. I do find degranulating with a good curette can be just as good. Which consistency do you put the EthOss in for sinus lift? Do you elevate the sinus membrane? Yes, so sort of just putting in a sort of a reasonable mix. It goes in so that it's not too hard that it's going to cause any damage to the membrane, but not too soft that it can't offer any resistance to the membrane. It's kind of like an in-between mix. Before you put the EthOss into the sinus, for example, with yeah, that was it. I just answered that one. Haven't had, like I said before, haven't really had any experience or need to mix it with anything else, because it's just worked reasonably well. I mean, perhaps you could use RPF as a sort of cover instead of using a collagen sponge, perhaps. In sockets with buccal plate loss, which extend, do you pack the graft? Would you cover over contour or just fill the socket? So I would probably, I mean, I always try and just fill the socket and probably not over contour. If you're going to have any trouble with closing, you might find you've just over contoured it, or you've just put a little bit too much. I mean, really, with this material, it's unusual, and even I have to struggle and fight sometimes not to place all the material that I have in the syringe. But I do find that less is often actually more. I think with some other materials, we can expect a sort of percentage reduction in the amount of material that we place. but with the as long as there's enough material and we've got a nice closure, it performs really well. So we don't have that same sort of reduction in volume. Will you graft next to an implant if there is a gap after immediate placement? Yes, depending on if it's a tiny gap, then probably not, a millimetre or so. If it's any bigger, then yes, I would. And I'd go for the umbrella sort of socket healing technique, probably with a provisional over the top. Yes, Gelatemp is your collagen sponge. Are those the brown ones, little brown ones? I tend to use just the sort of standard collagen sponges. I think they're by Septodont, but I'm sure they're all very similar. Can you explain the procedure when doing vertical bone graft? Franz, yes. So when we're trying, basically what I've covered here is sort of onlay and veneer grafting that helps increase the sort of amount of bone that we're getting by sort of 2 to 3 millimeters, allowing us to place. So say for the mandible, for example, one of the things that I always thought I had to do was I thought I had to sort of decorticate the mandible and punch a load of holes through. Now I'm finding if I'm just placing the EthOss over the top, usually at the same time as placing an implant, I find that the implant, especially with maybe a small, not quite a healing abutment, but with a sort of 1 millimeter high cover screw, you can get a tenting of the soft tissue, and the tenting effect with bone graft works really well. When you are cleaning, do you place anything in the socket to disinfect? So yeah, I use the saline to clean everything, and then one material that I've been using a little bit recently is just Blue M gel. It's just an oxygenator and just a fairly gentle sort of bug killer, and just leave that in there for sort of a minute or two. But I just find it works so well with soft tissues. I've just been using it as a sort of preface to applying the material, but I don't use it all the time. After extraction, you can have up to 60% bone resorption horizontally. How much resorption do you get with EthOss, and how do you use it in aesthetic cases? So when if we have bone loss in an aesthetic case, depending on what you're going to do with that site, will determine how you manage it. So yes, you get up to 60% bone loss horizontally. With EthOss, you're not getting as much as that, because you're causing a upregulation of healing in the site. So we tend to find that when we socket preserve in the front, we place an implant at the same time or soon after, we're getting really good results, and there isn't any visible sort of loss of contour. So in an infected site, is it better to leave for a few weeks and degranulate and graft? So yes, Michael, this is another option as well. So you can, if it's a really infected huge site, one of the other alternative options is just to let it settle for 5-6 weeks and then come back, graft, and then overlay your sort of immature but really handy soft tissue that helps protect the grafts, and it just sort of helps everything sort of settle, seal, and heal underneath. So that is a good alternative in a really big case, in a really big infected site. EthOss available in the United States? Not yet, but I know the team's working hard to get it there. Would you ever place a PTFE membrane over EthOss instead of a collagen sponge? Yeah, perhaps you could. I quite like the collagen sponges just because they're resorbable. I have been doing a little bit of work where we've been using little sort of bacteriostatic pieces of plastic that can be malleably placed over the site, and they just help close everything. They just help keep everything sealed and closed. I think last question now, Islam, in your last few cases where you're increasing the bone height, how do you close the site? What goes over the bone? So it's just the periosteum that goes over the bone. So I tend to, rather than sort of periosteal releasing incisions, tend to open slightly in those sort of posterior mandibular cases, slightly longer incision towards the back of the mandible, and just close up over the top. Okay.